Okay, we're recording.
Good evening and welcome everybody. I'm very happy that you can join me this evening to have this meeting of the Mental Health Board. Okay, let me use my cheat sheet. Okay. The Mental Health Board, who we are. The Sonoma County Mental Health Board is an advisory board empowered to listen to the concerns of our constituents and to help formulate policies that offer a consistent continuum of care for all those with mental health challenges. We are further empowered to advise the County Board of Supervisors on the mental health system of care. We support reducing stigma for individuals needing all levels of mental health care in all communities in the county, treating each person with compassion and respect, regardless of gender, sexual identity, and cultural or ethnic background, and acknowledging the influence of individual lived experiences. Working with the local mental health system to eliminate racism from our minds and hearts, and ensuring that our policies are equitable and benefit underrepresented communities. Acknowledging the environmental factors can increase mental distress and supporting effort to reduce such stresses. We also support providing support to the families of those with mental health challenges. The Sonoma County Mental Health Board collaborates with the Behavioral Health Division of the Sonoma County Department of Health Services to increase public and professional awareness of individuals with mental health challenges. We strive to influence positively the mental health system by listening to public input and working with behavioral health science services to create policies that will offer hope to individuals living with mental health and to their families. Okay, should I call the meeting to order? I would like to move a motion to approve the minutes with the corrections. Did everyone read the minutes, or did anybody read the minutes?
I second.
Approval.
Okay, Bill. Thank you.
A point, Peterson.
Yes, sir.
Should we go through a roll call prior to any business?
Yes, we should. Trying to bounce back between the two papers. Yes, we should. One moment. Annabelle? Okay, Betsy?
Here.
Okay. Bob Cobb?
Here.
Carol?
Yes.
Okay. Kathy Smith is absent. Miriam? Michael is absent. He sent excuse. Patricia? Peter? I'm here. Robert Hill?
Here.
Vanessa? Okay.
Here.
Okay, thank you. We have vacancies in District 2, 4, and 5. And Peko Elishan Maria, is she here? The intern? Okay, that's the end of the roll call.
You didn't call my name, I don't think. Peter McElweeny.
Yes, I did.
Oh, you did. Oh, I'm present.
Thank you. Okay. Consumer Affairs Report. Is Kate here?
Okay.
Can you hear me now?
Yes.
Yes, I am. We're going to have a guest tonight who's going to speak with us about peer certification. And that's Carol West, who knows that system quite well. So she's going to let us know what's going on.
Okay, Carol, take it.
Okay, so that's me. I'm also a mental health board member, District 2. Before I start, I'm hoping at the end of the presentation to ask the mental health board whether the mental health board can host a peer certification forum, which would be in early August. We do not have a meeting in August, but we have a pretty quick turnaround timeline for peer certification. So hoping that the mental health board will consider that. Can I share my screen?
Oh, sure, go ahead. Tori will allow you.
Okay. Oh gosh, I lost my mouse. There it is. It says host is disabled, participant sharing.
Try it again. I just
Try it again?
made you a co-host. Yeah.
Okay, thanks. Okay. Okay, so there was a third listening session at Department of Healthcare Services let me start again. SB 803 is the Peer Support Specialist Certification Bill that passed in September last year. And they're in the process of implementation. The background is that peer support specialists are recognized in, I don't want to read all these slides. Oh gosh. All right, this is going to take too long. So I'm going to quickly just highlight what I have here. So basically, SB 803 authorizes the Department of Healthcare Services to create standards for peer support certification. And then counties have to opt in. This is a choice that the county has to go through. And the process that the county goes through would be based on the standards that have been set by the DHCS. DHCS has in fact got a draft of the standards already, even though the timeline is for them is a little bit later, I think January 22. They in fact have it ready to go, and I have some of that information here. So what DHS has already done in conjunction with peer partners, including organizations like the California mental health peer run organizations. They are defining the qualifications, range of responsibilities, practice guidelines and supervision standards, determining the process for initial certification, curriculum, core competencies, and code of ethics, recertification processes. So basically the nuts and bolts of how all this is going to work. The standards have in fact been drafted by DHCS, and we're in the process now of moving to the county level. Counties now have to decide if they want to opt into certification or not. The certification is specifically for Medi-Cal reimbursement, so it does not impact peer programs that are under other peer funding sources. But what it does do is, which is new, it allows for billing for peer support specialist services if the county certifies their peers. So who it'll affect, people who are 18 years of age or older. They must possess a high school diploma or equivalency degree, be self-identified as having experience with having lived experience of behavioral health or substance use disorders, either as a consumer or as a parent or caregiver. So it includes both consumers and family members and caregivers. Individuals must be willing to share their experience, have strong dedication to recovery, and then agree in writing to adhere to the code of ethics, and successfully complete the curriculum and training requirements, which are all detailed, and then pass a certification exam approved by DHCS. There is going to be reporting requirements, and then these are important dates. DHCS has encouraged counties to take advantage of CalMesa to help them with the certification process. And any county not working with CalMesa must decide that by August 1st. So that's a deadline that's coming up, and let DHCS know. So this is all the program details, blah, 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 fish cakes. And then this is the hard deadline, is November 19th. So if counties decide they are going to opt into certification, they must have a written plan submitted to DHCS by November 19th. This is the contact information for where this goes. It's and then this is a request again. So this is an action that I'm hoping that the Mental Health Board can take today if we have a quorum, is that we have, and I did speak to Kathy this afternoon, so she does know about it. So I'm asking for the Mental Health Board to host a forum for consumer input. So both for information and to discuss whatever's on their mind related to peer certification. So Peterson, I'm not sure if what the process is for that.
I think when we are discussing the planning stuff, we can discuss it about planning.
Okay.
Carol?
Yeah.
Yeah, this is Kate. I'm wondering if really quickly you could run over like the statewide work group and how peer voices kind of work, how we worked to have those voices worked into the final draft. Because a lot of peer work went into that, and I want to, sort of
just highlight that.
Yeah,
sure. Several of our peers local to Sonoma County were involved in the work groups at CAMPRO, California Association for Mental Health Peer-Run Organizations. And that is a state-level organization that is funded for the next 3 years to be the peer advocacy organization for California. And DHCS worked very closely with CAMPRO. And so we had 11 work groups, one for each of the standards that were to be set for peer certification. So it was definitely a grassroots organization effort. And each of the work groups actually had about 20 people in them from across California, from the peer advocacy organizations. They in fact are continuing to work with CAMPRO and with the work groups through LEAD. And I can certainly connect you with those work groups if you're interested. And the intention, I believe, is to help local groups that are deciding to move forward with peer certification. So to help the counties better understand what's involved. they will also be working with CalMesa, I believe. So that what happened basically was that the California Behavioral Health Directors Association, and I'm not sure if Bill's here, he may be able to fill us in on this. They decided that it did not make sense for every county to be going through this process on their own, and it was going to cost a lot of money, and they could save money and share administrative costs if they combined and chose an organization that could do it for everybody. So CalMesa was chosen. And so the intention is that they will give the technical advice and help with the program planning for peer certification for any county that wants to. There is the option to go it alone. So maybe big counties like Los Angeles may decide to do that. But I think most counties are choosing to go with CalMesa. But the peers were, in fact, the legislation was peer driven. This was grassroots driven over the last, over many years, but the current legislation failed 3 times before it passed. So this has been a long time in the making and has been a grassroots effort. Yeah, so we're really, really hoping that Sonoma County will decide to say yes. You know, one of the biggest stumbling blocks is that there is a cost involved. The counties have to come up with some funding to help CalMesa with the implementation. So, you know, really kind of looking at where that money is going to come from, I think is one of the, as they say, the short pole in the tent. But I think it feels really important that we do have the peer community involved, and the families and the caregivers and stakeholders and service providers, and that we do have a conversation, and that this is something we do as a community. So that's why I'm hoping that the Mental Health Board will help us convene.
I have a couple of questions.
Yeah.
First, have any numbers been crunched to determine if the reimbursement is going to be available, if that would help support some of the costs of implementing the county programs?
I don't know the exact numbers, but certainly the carrot in this whole process is that if counties choose to go through this process, that they will be able to bill for peer services that are under Cal Medi-Cal, sorry. It does not affect obviously reimbursement for programs that are not billed to Medi-Cal. So it is limited in that capacity. But my understanding is that not only will that Medi-Cal billing be available, but that the Cal-AIM innovations or changes are moving away from fee-for-service and towards value-based care. And so there is a lot more incentives to incorporate and include peer services across the system. So there are multiple opportunities for different funding mechanisms for peers. There are also new funding, in fact, a lot of new funding coming down for community health workers. And in certainly the bigger cities, peer support specialists are being hired into positions that are listed as community health worker positions. So there's multiple funding opportunities for paying community health workers and supporting peer support specialists in across the system of care.
Second question, Carol. I'm not clear on what appears to be a sense of urgency about a forum and who that is going to include, who it benefits, and what the outcome may be anticipated, what you're looking for about the form you're speaking about. Could you kind of cover that, please?
Sure. So the August 1st deadline, I think we probably will not be able to have a forum before that deadline. That is when the county has to decide whether they are going to go with CalMesa or not. That is a soft deadline in that there's an assumption that you will go with CalMesa if you choose not to say anything. The hard deadline is a written proposal by November 19th as to how the county will implement peer certification, which begs the question is, has our county, Sonoma County, decided to move ahead with certification or not? So it is an opt-in legislation. It is not automatic. The reason they did that was so that the counties would have to pay, would have to help pay for the implementation. Other states have centralized peer certification, in which case there is funding that comes down from the states to the counties to help with implementation. So this was a trade-off to get this legislation passed. So standards will be set by DHCS, and they in fact have already done that. They're ready to release their, what's it, a BHNIN, Behavioral Health Information Notice. I've seen the draft, and so they're pretty well ready to go. I'm not sure if that answered the question. Why do we want consumer input?
Well, not necessarily. I'm assuming that all along this process, we've been soliciting and collecting consumer input. So what does this accomplish that has not been previously worked through? The other thing, if you tag an answer onto it, is this a Board of Supervisors decision? Certainly we can advise, make recommendations, but who makes the final decision whether the county opts in or out?
I would assume that ultimately it's a budget issue, and that would be Board of Supervisors, but that would be informed by Bill Carter at Sonoma County Behavioral Health. And that would probably also primarily be a budget issue. My understanding is the theoretical discussion about whether we should or should not have peer certification is yes, it would make sense to do that. But ultimately, I guess what I am hoping is that we do have a robust conversation, community conversation, as to whether, number one, we want peer certification, and number two, if we do want it, what concerns do people have, and what avenues for input do they have, specifically the peers themselves. People who will be impacted by this process. And that includes people who are family members who are acting as supports to a loved one with behavioral health challenges. So peers are not just peer consumers specifically, it does also include substance use and family members. Sorry, 1 second, my dog wants out. So it's going to affect a lot of people whether we decide to move forward or not. And has there been input? I think there have been individual conversations. So, I'm sure Bill Carter has spoken with West County Services and potentially, substance use disorders, but has there been a community conversation? No, there hasn't.
Thank you.
I'm interested to hear from Bill Carter about what he's heard out in the community or his conversations around this topic?
Um,
Yeah, so our interest across the board is to add peer support services to our system, both in county programs and in our contracted programs. As Carol described, up to now, it's been too difficult to add those services through Medi-Cal. What you have to do with Medi-Cal is really works against peer support services. Medi-Cal requires you to be very deficit oriented. Peer services are very positive. And then, you know, the lack of professional license and such has made that difficult. So the certification is a first step in creating an opportunity to identify a group of people who the state recognizes as qualified to provide services. And then the second step is to have a way to bill for services. So in general, we believe the state is going to come up with a way to do that. There is no specific plan that I'm aware of. I know that, you know, with things like CalAIM happening, whenever, you know, whatever they do with renewing waivers, my assumption is they're going to create opportunities for us to bill peer support services. But for right now, there's no specific avenue to do that. So we have, you know, peer training program that's operated by West County Community Services. It's an effort that is a standing effort to train peer support specialists. What we would like to do is, you know, take it to the next level and begin to certify those folks and place them in internships in our programs and create a career ladder. So in general, everybody in the mix is supportive of that. What we don't have yet is a clear path for how to get there.
Okay.
Great, thank you.
Thank you, Bill.
Peterson, there's a question and answer from Mary Francis. She wants to know, will existing peer specialists need to take the new standard PS training, or will they be grandfathered in with some form of testing or abbreviated training? Who would write the plan that would need to be submitted by November 19th?
Thank you for the question, but Carol, can you answer to that at all?
Yes, there are very specific grandfathering in requirements. I can certainly share the document with Mary Francis or with anybody else who wants it. Right now it is, I don't know the details offhand. I have it right here, but I don't know that we have time to go through it right now. But yes, there is a very specific process for grandfathering in. And a lot of time and effort went into making that decision, those decisions.
Okay.
Yeah.
I hope that answers
So
Mary's question.
I guess, how will that look like in Sonoma County? What exists right now are the standards that are coming down to us from DHCS. How we implement that and what that looks like in Sonoma County is up to us. So there's a lot of room for community input. But I guess how much room is there if the standards are set? I guess not that much. So, so the short answer is yes, the standards have been set. And so it's, you know, it's X amount of hours. And, you know, I think there's 3 letters, 1 from yourself and 2 from previous employers. And so, yeah, that has been set.
Okay. Thank you, Carol, for your presentation. Any other question for Carol, anyone?
No, I guess to Carol's point, I just would want to know, other than endorsing this effort, Carol, what more can we do as a board to support this effort?
Well, my hope is that tonight the board will agree to host a forum, a community forum, to share the information about SB 803 and to go more specifically into the details of the standards that are being proposed and what that might look like for us here in Sonoma County.
And I would assume that it involves all community partners that are on board with this bill.
Whether they're on board or they're not on board, there may be people who do not want us to move forward. So I think that discussion has not happened. My understanding, and personally, I hope it does move forward. But I think if we, this is a fairly big decision and it's going to impact a whole workforce of people who, to my knowledge, have not been included in the decision-making at this point. So if we truly want to be, to have a consumer input, now is a good time to do that.
Yeah.
There's a question from Becky Innes. He said, what are next steps before August for community to be involved?
There are none. So that's why I'm asking the mental health board to facilitate a forum for us to take the first step. That's not to say that the county has not been looking into this. I mean, Bill Carter will tell you this has been on his mind, and he has had multiple conversations, I'm sure, with multiple organizations that can and will be impacted. But have we had a community conversation about SB 803 peer certification and what that means for us, whether we want to move forward, whether we don't want to move forward, what the standards look like, how will that impact our workforce? That feels like at least one conversation would be a place to start. And I think that the mental health board as a consumer advocacy group is a good place to start with that conversation.
I want to agree with you, Carol. I also, just in knowing the shortage in licensed clinicians and the mental health need, and everything that we have coming on, I would imagine that this would be a really great, not a solution, but at least a positive roadmap to addressing many of the needs of our community. But and so would you need a vote for something like this? I would be interested as a board member to support this, but how do we move this?
Yeah, that is my understanding, is that we need a quorum and we need a vote to say, yes, we can move forward with having a mental health board sponsored forum. How I imagine that would work out would be that we would have a date and time and a Zoom meeting, and that we would have people from the peer centers, people from Buccaloo, people from Providence, people from Voices, people from the mental health advanced care directives, mobile support team, whoever is interested in potentially employing peer support specialists and supporting them, with the understanding that peer certification is, will be impacting the Medicaid population. It's not going to, help really with the payment of non-Medicaid programs, but what it will do for those programs will also create the standardized training and recognition for the workforce, even if it's not going to help them with their particular funding issues. So I think there are, yeah.
Okay, there are a few comments on the chat. Becky again said, The Health Action Council meeting on the first Friday in August is dedicated to mental health. This could be a good community forum for discussion with many members of the community. And there's also a recommendation that Mary Frances should chair that. And also, Peter said, has there been proper notice that a vote would be made on this issue at today's meeting? No, there was no prior notice on that, Peter, and we were hearing it for the first time at the meeting.
So I guess I don't know what the technical next steps are. You know, whether we have to take this to the executive or, you know, whether we have to give a 30-day notice, or I'm not sure what the protocol is. I don't know. Bill, do you know what the answer to that is? What the kind of Brown Act implications are?
This is not an area, I'm sorry to say I have expertise, but I do agree. I do have a general understanding that you need to notify the public when you're going to be voting on things. So that may be an issue.
Can I make a suggestion that, we don't have a meeting next month. I would say, should we take it to the board and discuss it and then decide where we go from there? What do members think?
Well, can I just ask Bill, so that we can get the August 1st deadline out of the way, that if we move forward, we would be going with CalMesa, is that correct?
So I think so. Carol, I've not been able to find an August 1st deadline. I've been in communication with the executive director of CalMesa, and she tells me that they're going to present a project at our next board meeting, the CalMesa board meeting in August. So I will tell you in general, I can't commit to anything I haven't seen, but I will tell you in general, I'm highly inclined to join a project to bring peer certification to Sonoma County. I'm highly inclined to join a project that is part of a collaboration, a statewide collaboration such as CalMesa's. So I would expect to, but I've got to wait until they offer something to respond to.
Okay, so the application submission requirements, DHS encourages counties to take advantage of the opportunity to work with CalMesa for their certification programs. Any county not working with CalMesa must notify DHCS by August 1st, 2021. Counties can send this information to DHCS via, and they have an email. So that came out of the bin here. Oh gosh. Anyway, so it sounds like yes and yes. So that pretty well gets rid of the August 1st deadline, which then really opens up the timeline to November 19th. So then we do have more time and wiggle room. So there's less pressure, to make a decision this evening. So what I'm hearing is that we need to go back to the executive and then we need to post this as a decision and potentially look at other opportunities for creating the forum elsewhere if it's not going to be under the mental health board.
There was that suggestion as well from Becky, and but we can take it to the executive meeting.
Okay.
So then it might appear as an agenda item for the September Mental Health Board meeting. Is that what we're discussing?
I think
we don't have a meeting in August, so yes.
Yeah, I think that was really my concern, is that we are in July right now. We have no meeting in August. September's meeting is the presentation from MSHA. And so we are then, September, October, November, we've got 3 months. So it really felt like if we missed tonight as an opportunity to make a decision, or at least get an endorsement from the mental health board that we would like to have community or consumer input into this process, that we're waiting until September, and then October, November, we've literally got 2 months. I don't know that we can do much with that. You know, this is complicated stuff, and I think it requires at least, I would imagine, several meetings to talk about in depth what this is going to mean to our county. I was hoping that the mental health board would be supportive of that.
I think, Carol, that part of it is that it isn't whether we're supportive or not, but if you're going back to Brown Act and pre-posting agenda items which are on the topic so that so transparency is there and public opinions may be contributed, that's required. And since that isn't the case at the moment, no attendee that I'm aware of knew that this topic would be brought up today. So our hands are a bit tied.
Okay. Well, then the question is maybe back to Bill. You know, can this not happen under the auspices of Sonoma County Behavioral Health? That there is a community forum that is an open discussion about SB 803, what the letter of the law is, what DHS has set as standards, and what the implications are for Sonoma County.
Yes, we can do that. You know, I've been waiting until we know more about what we're responding to. So I'm just a little unclear as to what we would do it in a forum right now. But if consumers and folks have ideas about this and want to work with us to create a forum, we can do that. I also see in the chat there's suggestions that Health Action that we take advantage of existing community stakeholder groups to do this. But in short, yes, if there's a group of folks, stakeholders with interest in this, we would be happy to convene an effort to discuss it further. Again, I would need some direction as to what to discuss absent some specific opportunities. We just have nothing to respond to right now.
I think that the BIN, what does they call it? The Behavioral Health Information Notice is, I have a draft of it. It has not been released at this point. I think it's like a 40-page document. I think that gives us a lot to talk about. That sets the standards, and that would really give us, you know, if we did an equivalent process that we've done with CamPro, what you do is you look at the 10 or so tasks that need to be implemented to create a process, and you know, look and see what that would look like in Sonoma County.
Would it be useful to include West County Community Services and any and all aspects of the peer groups that they're managing, since certainly a good part of that population is interested in, will probably participate in whatever the outcome is?
Yeah, I mean, from my perspective, yes, because they are, you know, our primary partner in this area, in that we have contracts with them to provide related services. You know, there's also the issue that I need to be careful not to have this be too mental health focused. There's an SUD, you know, stakeholder world that is very interested in peer support in that area as well. So, and then I know that just in exploration we've done, we're interested in, you know, looking in developing a partnership with a Latinx organization or organization that's particularly plugged in or a part of the Latino Latinx community, maybe someone outside of traditional behavioral health to work with us in this area as well. Again, just brainstorming talks, nothing significant, but I'm just trying to make the point that I'm also aware of different stakeholder groups within the peer support community that we want to do outreach to as well.
Right. Because one of the other areas that would be impacted is the criminal justice and parole, reintegration. My understanding is that Transitions Care Network have individuals in Sonoma County through Sonoma, Santa Rosa Community Health Center that, and I think funded through Whole Person Care, who meet people at the jails and help them reintegrate, and that there is the intention to hire more individuals who are coming out of the incarceration that would be employed as peers. So, you know, West County services are for sure important, and as are all the peers that are employed. But I think the intention with peer certification is that many more individuals can be trained and integrated into all areas across the system of care.
Okay, without cutting across the call, I realize we won't have an answer from this meeting this evening. So I think we should make that an agenda item for our next meeting, executive meeting, because we've been discussing, and then we have a special presenter, and we've already passed the time, so we've gone way past the allotted time. So I think we should.
Chair, if I may,
Mm-hmm.
I do think that Carol's point is really important, and this topic is very important moving forward. And because we are skipping August meeting, it is at least for the board to endorse the possibility of having, or the option of having a community forum to learn, to hear from all parties, all throughout the spectrum about what they feel, how they feel about this particular matter, and also filling in gaps that Mr. Carter has pointed out, as well as Carol. I think those are very important things to talk about as a community collectively. And also in terms of transparency, I think that's a good opportunity for us to elevate what we've been talking about through our retreat. Is one of our goals is to elevate transparency and community conversation. So if we could at least commit, I think as a board, that we're interested in hosting something like this in the future, then when we come back to this conversation, we don't have to take it from this point, and we can start it from where we left off and move forward.
Mm-hmm. Yeah. Well, I just want to thank the board for taking the time to talk about this. It sounds like there are multiple options, and there are multiple agencies that potentially could help us to create this forum. We can table it to our next executive for formal mental health board endorsement, because I think that is important, since the mental health board is the consumer advocacy group or avenue in Sonoma County. So it feels very important that mental health board is contributing or supporting or endorsing, whatever we call it. But it sounds like we do have multiple avenues to move forward. So I do appreciate the conversation. Thank you.
Thank you very much. There is also a suggestion by Vanessa. She said, Carol, this forum has to be through the mental health board. Can a few of us lead it outside of mental health board to have the forum in September?
Yeah, so can it happen outside of the mental health board? Yes, absolutely. But I'm still hoping that the mental health board will be involved in some shape or form. Vanessa, I'd be happy to speak with you and see what we can do. And it's certainly, if we can check the notes from the chat. I haven't been doing that, picking up on whatever other suggestions people have to make this a reality. I think there were some very good ideas. Thank you.
Thank you. Thank you, Carol, for your presentation. Very interesting. Public comments? I think we got quite a few. I don't see any hands up. You see any, Tori? No. Okay.
I do not see any hands.
Okay. The special presentation by Wendy. Is Wendy with us? Yes. Okay. Wendy, the floor is yours.
Erica is going to assist me.
Sure.
Is it going to be okay with the board if I go past the 6:15 mark, since you took up
Yes, we took
most of my
our-
presentation time?
Yes, yes. Fair enough.
Okay.
Yeah.
All right. Can you see my screen? Somebody give me a thumbs up.
Yes.
Okay, thank you. All right, my name is Wendy Wheelwright. I am one of the co-chairs of the Quality Improvement Committee at Sonoma County Behavioral Health Division. My current role in behavioral health is the Adult Services Section Manager. I am the outgoing Quality Improvement Manager. And so my co-chair is Erica Chloe. If Erica would introduce herself.
Hi, everyone. Can you hear me okay? Okay. My name is Erica Chloe. I work at Providence. My role is access to care, community behavioral health, and I am the co-chair of the Quality Improvement Committee.
And so we were invited to come present to you a little bit about what the Quality Improvement Committee does. And I'm going to refer to it now as QIC, that I've said it a bunch of times because it's rather long. So I'll be referring to it as QIC from now on. And so what we're hoping to cover today is what are the requirements of a QIC? What's its purpose? What's its responsibilities and activities, and how who's represented in the membership? And that's part of the regulation that governs what a QIC does. And then we're going to talk a little bit about some examples of projects that this committee's taken on, and I'll talk about the process by which we analyze issues in the system and put projects forward using that example. So if that works for you, I will proceed, and I will be sending these slides to Tori so that she can send them out to you. So I'm just going to start first with the requirements. It is a requirement of a mental health plan to have a quality improvement committee. It's required by federal regulation as well as our contract with the state. And the quality improvement committee is required to monitor the service delivery system with 3 specific goals. We have the goal of improving the processes in that system, trying to ensure that we're providing the best care in the system, and figure out ways to better meet the needs of our beneficiaries. So that's the main purpose for which a QIC exists. It's specifically responsible for reviewing the quality of especially mental health and substance use disorder services provided to beneficiaries. And I'll go into that in a little bit more detail when we look at the particular areas that we assess. And then the QIC is supposed to make recommendations on policy decisions based on what they find, and review and evaluate the results of any of our quality improvement activities. The QIC also plans, designs, and implements quality improvement activities as needed to improve the quality of services and ensures the follow-up on those processes. And some of the specific quality improvement activities that we might engage in are going to be very nerdy, but there's a lot of very nerdy people that join this group, so it works out. So we do a lot of collecting and analyzing data to measure against our goals or prioritized areas of improvement. And so we kind of look at the system data and see how are we doing? Is it showing a problem? What can we do to fix that? And when we do try to put something in to fix it, does the data show an improvement? What does it mean? So we spend a lot of time looking at the numbers. We use that to identify opportunities for improvement, and we use the committee to gather stakeholder input on deciding what opportunities to pursue. Where do we want to focus our efforts? Make little subcommittees to go after that. We obtain input from providers, beneficiaries, family members in identifying barriers to delivery of good care, and also to identify barriers in the administration of our services. And so some will be clinical issues and some will be non-clinical issues. The group helps us to design and implement interventions for improving our performance. And the group helps us with measuring the effectiveness of that and looking at consumer perception surveys and things like that. And the group helps incorporate our successful interventions into our operations as appropriate. So they'll make recommendations based on our findings for what might be incorporated permanently into our system. So I'm going to talk a little bit about the membership before I hand it to Erica for a second. So QIC has a broad group of stakeholders that are involved. I've just highlighted a few of the areas that we cover. We do have members that are part of behavioral health leadership, they're managers, supervisors. We have quality management staff that are part of the committee. We also have clinical and administrative types of staff from various organizations that are part of the committee. We have clients, consumers, we have family members, we have patients' rights advocates invited to that committee. We have our contracted community providers, lots of representatives there, and we have some of our community health organizations that are involved as well, like Sonoma County Indian Health Project and some others. And Erica, in fact, is with one of those as our co-chair. So I'm going to go into sort of the process of how we do what we do, but before I do that, I thought it would be good to give an example of a project. So Erica, if you wouldn't mind taking that away for a minute, go ahead.
Of course, I'd be happy to. So we've done a lot of pretty amazing work in QIC. We have a really great community that wants to see positive change and to increase access. One of my favorite projects that we worked on as a group was our mental health crisis call brochure. And so this particular brochure helped individuals that might have to call law enforcement during a mental health crisis. It was very confusing for people to figure out what to say, the language that was used. And so we created a brochure that had all of the correct emergency numbers on it. We vetted this brochure through all of the different areas. So we talked to dispatch, we talked to law enforcement, we talked to family members, we talked to individuals with lived mental health experience, we talked to providers, and we created this brochure to decrease the risk by increasing effective communication with law enforcement. And so I can drop the link into the chat, but it's one of the projects that we've done through QIC that really saved lives. Because if people know how to effectively communicate with inside of a crisis and get people to the right level of care, whether that's emergency crisis support or a different referral, it's important that we have the correct language.
Thank you, Erica. So just to kind of look at that process a little bit of how we selected that specific project, let me first start with a couple of definitions so we're on the same page. Quality improvement generally is the use of a deliberate and defined improvement process and the continuous and ongoing effort to achieve some kind of measurable improvements in efficiency, effectiveness, performance, accountability, outcomes, and any other indicators that would improve the health of the community. Performance management, in this case, is our use of data for decision making. So we would set objectives and then we measure and report progress toward those objectives. And we engage in quality improvement activities when the desired progress toward those objectives is not being made. So in the case of the example that Erica just detailed, we had, what prompted that was, unfortunately, mental health consumers historically have been at greater risk for officer-involved shootings because when they're in crisis, the crisis may impede the ability to follow commands and things like that. And we had some very sad encounters at that time in the Roanoke Park area. And so it was a collaborative effort between the QIC and law enforcement of what can we do as a community to try to prevent these very tragic outcomes. To try to lower the risk for our beneficiaries who are loved ones of ours, who are friends, who are ourselves, and our community members, and what can we do about that? So we first had to go out there and look at data. We had to first explore with the community, what is the perception? What stops people from engaging help in a crisis? What are the fears? And so we had to do some surveying and some stakeholder input and community process to identify what was going on, and then try to figure out, based on that, a good intervention that would help. And so in talking to the community, there was a perception that I can't call for help when I need it because I'm afraid of what might happen. There's a big, huge unknown in what that's going to look like. And so as a committee, we decided to work together with law enforcement to try to demystify that process and try to come to a shared understanding of what could happen in the encounter. And so they became a stakeholder in the process as well, in order to inform what we were going to put out for that brochure. So it kind of looks like this. We start with, what are we trying to accomplish? Well, we wanted to improve safety for everybody. How are we going to know if the change is actually an improvement? Well, we'd want to see a reduction in these very serious incidents. And what changes can we make that are going to result in the improvement? So that's when we discuss a lot of different things. And one of the things that law enforcement initiated themselves directly was what's called the crisis intervention training. You're probably familiar with that as well, as that is something that's been discussed with the mental health board before. But that's something that behavioral health partners with them on, to have a special crisis intervention training certification that officers can go through, specifically around how to engage people that are dealing with mental health crises in the field in a way that's going to be more effective. And so that was something that they had sought out, and then we wanted to partner on this process. And so we decided to develop the brochure with their help of, all right, you know, in a crisis, it's harder to communicate. It's harder to find the words. What do you do? And we realized that a lot of our partnering organizations that we work with, community providers, dealt with crises a lot, and they had scripts that they would use with their staff to try to help communicate the most effective information to law enforcement to try to set the tone for how that engagement would go. And so we collaborated together and combined those scripts and vetted it through dispatch in order to come up with that brochure. So the guiding principle that governed what we were doing was, first, whatever we're doing has to develop a strong client focus. So the whole purpose of it was to improve the safety and outcomes for our beneficiaries, for our friends, our loved ones, our community. The other guiding principle is we want to continually improve all processes. So is this something that we take on is going to be helpful, not just to us, but could be helpful to the community at large, could be helpful to other safety net processes. So that's something that we look at. We wanted to involve stakeholders, so we did. We involved community members, peers, family members, law enforcement, dispatch, all different branches. We did a lot of legwork on that. And then we want to mobilize both data and team knowledge to improve our decision-making overall. So that's how this project came to be, is by following these principles. And it kind of looks like this little picture for you visual thinkers. We start with, where do we want to be? You know, and then how will we know if we get there? We've got to measure that somehow. And then we got to monitor it once we put it in place. How well are we doing? How well is this being utilized? Are we seeing a real world impact? And then once we achieve that, all right, how will we improve next? And it just keeps going in this circle. So as we're doing that, when we have to develop, one of the trickier parts for QICs, we have to develop the metric by which we're going to measure progress. And that's more of a math nerdy thing. So I'm going to try to break that down in less math nerdiness. So the first thing we assess is, what's our current state? It basically establishes the kind of right now regarding our key system priorities. So we try to have a clear picture of what's going on right now before we throw a bunch of interventions at it. It's not uncommon when you're trying to problem solve that we don't always have a clear picture of the actual problem. So we want to make sure that we're hearing from the community and stakeholders to clarify what is the actual problem we're targeting. And then we try to get clear on where are we going. What's the clear goal that we're heading for? And then from there, we want to put in some kind of evidence-based performance measure that measures the gap between those two things so that we know that we're making progress. We do that and set goals based on what's called the SMART test, which means, is our goal specific? It actually says what we're going to do and uses action words. Is it measurable? Is there actually a way to know that it's working? Is it attainable? Because we have lots of wishes and desires for the system that sometimes aren't actually attainable. So we want to make sure we're targeting a goal that we can do. Is it within our scope to do it? Is it relevant? And this one was very relevant to the community interest. And is it time bound? Do we have a definite start finish of when we're going to be able to develop, implement, and produce results? Within our system of care, quality improvement measures 4 common areas, and these are them. We look at access to care. We want to know numbers of clients served, different populations that we're serving, and are there barriers to service that we can take down in order to help people get into our services. Then we look at how timely are we delivering those services. It's one thing if we can get people in the front door. It's a whole other thing if we then make them wait a long time before we'll actually meet with them. So we want to make sure that those 2 things are joined very well together. We also look at the quality of our services. So we talk to our clients about how do you like the services you're receiving? Do you have suggestions for us? We look at the quality of the design of the system. Are there obvious, gaping holes that we need to fix? And we look at various evidence-based practices that we've implemented, and are we implementing those with fidelity, or do we need to do little training tune-ups? There's a lot of training involved in that section. And then the last thing we look at is outcomes. It's one thing to ask, do you like your services? It's another thing to ask, are they working? So we want to ask both of those questions. Is it actually showing an improvement in your life in the area that you were expecting it to? Is it showing it clinically, functionally, and time and cost saved is another area of outcome that becomes important to the QIC. So that is kind of the quick version of how we go through a project arc in selecting what we do. And then in general, we have kind of a toolkit that we can pull from. I just listed them in case you're interested. I won't go through them all because they're flat. But we have specific tools we can use to help assess a situation. As I said, one of the key parts of doing any kind of quality improvement project is clearly identifying what the problem is before you try to launch into 50 different ways to fix 50 different problems that we haven't actually agreed on. So we have all these different little tricks of the trade that we can use to narrow down what's the situation. Then we have specific tools that will help us make decisions. And so we can look at root cause analyses and various interrelationship diagrams to try to figure out how to decide which intervention to apply to where. And then we have some specific tools that help us plan the project itself. And so I have all of those listed out, and I keep a toolkit of each one of these. I have a worksheet for each one of these to help us do it if we want to go for it. I won't burden you with that tonight because that would probably be death by PowerPoint, as that would make this slide deck 100 slides deep. So I'm not going to do that to you. But nevertheless, you have the master list in case you should want it. So that's the quick version. I was trying to go a little bit faster. I managed to keep us in the window. Are there any questions from the Mental Health Board for Erica or myself?
I don't see any hands.
Great.
Oh, Carol.
Yeah, I'm wondering if there's any connection or interrelationship between the QIC and the MHSA community program planning process. And if there isn't, could there be in the future?
So MHSA has its has very specific regulations that it's under as well, and how it does its community planning process that Melissa navigates. We do actually work together. There are times when she has come to do presentations to the QIC to get stakeholder input from them on projects that are happening, to see where her projects can align with the things that we've identified in the system. Can we join together? Because there's a lot of work that we do analyzing, particularly equity and penetration rates into various demographic groups of our community that are extremely relevant to the work that she's doing. Because MHSA has funding specifically around outreach and early intervention and prevention. And so she needs some of the data sets that we develop. And we also consult with MHSA on the formulation of our goals, on the QI goals, because those are goals for the entire service system. and which includes large pieces that she covers. So a lot of our training goals and other goals are done in concert with her, as well as making sure that our plan aligns with the cultural responsiveness plan and the strategic plan, if that makes sense. So yes, those things are not done in a siloed fashion. They actually do communicate by that.
Thank you.
Any other question? Bob? Let's see your hand up, Bob.
Thanks, Erica and Wendy. I have an impression that has kind of been conveyed in some way that QIC operates kind of in the shadows, in the background, and not a lot of people seem to really know about QIC. You're giving us new information, but how do you respond to that perception?
Well, we had a similar perception. We actually put it as one of our goals on our QI plan, is to work on our outward facing communications and increase and improve those. So it's actually one of our goals for improvement in the system is to, we've got a 3-phase communication plan that we're working on. So we're looking at, at first we were working on improving internal communication of quality improvement activities so that the staff within the system were aware of that and were looped in. And now the quality assessment and program improvement section is working on a public-facing webpage so that the QI tools can be available to the public, so that our data reporting will have a more centralized place. And so they're working on that website design right now. That's the goal for this year, is to roll that out so that we have a lot more information going out. And then the third phase will be to implement a newsletter that goes out to our key stakeholders, probably on a quarterly basis, so that we can have kind of that 3-prong approach to communicating our activities and also soliciting project proposals from the stakeholder groups.
Can I add something to that, Wendy?
Sure.
So the other thing to think about with QIC is that every county has a quality improvement committee. And my understanding of Sonoma County is that we actually have quite a robust quality improvement committee. So there's a lot of people engaged and have been over the years in this process. And, that might not, there might be less individuals engaged in that process. A lot of people don't want to look at this sort of area of service. It can be kind of thick with policy and procedure and looking at data and all of that. So, not everybody, it's not everybody's wheelhouse. And so, although I think it's important that we have more outward facing, I also think it's really important to note that our quality improvement committee has been very active for many years.
Thanks, Erica. And I just want to add, though, Bob's point's well taken, is that, and it's something we were looking at too, of, we work on all these projects, we do a lot of things, and people know about the projects, they just don't necessarily realize it came from us. And so like, oh, you did that? And so we've had that response enough times that I feel like there's solid credibility to your impression, Bob. And so hence it became part of our goal set. It was in the plan last year. We did do it phase 1, and now we're rolling into phase 2. And so we're kind of rolling that out just to try to, improve the communication lines so that people are aware of the work that is being done, because there's a lot of really good work being done.
Thank you.
Thank you, Wendy and Erica. And also we would like to recognize Wendy for special appreciation. So I'll allow Carol Tori to do that for us.
And Peterson, I don't know if it matters, but I saw hands up from Robert and Carol.
Oh, you did? Sorry. You may have, I didn't see. My apologies. Go ahead, Carol.
I'll let Robert go. I've been talking a lot.
Wendy, just a question. Do you provide consultation to other agencies concerning if they want to improve services and develop criteria and they're asking for help? Do that?
Yes, we do. The quality unit, the quality section gets that kind of inquiry a lot. So we have we sort of have that divided into different sort of job domains, but we have a whole audits and monitoring section that goes out and conducts audits and reviews and will make recommendations specifically for improving processes. But we also have agencies that reach out to us proactively. And so there's an actual dedicated kind of help email. It's called BHQA, Behavioral Health Quality Assurance, where external providers will actually write in questions around it. How do you do this? Or, how do you chart, that kind of stuff, like more specific questions about doing it. And I get people that reach out to me as QI manager directly around, we're trying to implement a process. Can you recommend tools to do that? And so we do a lot of kind of sharing resources that way.
That's great.
Carol.
Thank you. Yeah, and my question was, has peer support been a topic of conversation at QIC? And if so, could they be of assistance in the next steps for implementation of the workforce or supporting the workforce as it moves forward?
Peer support is definitely been a topic at QIC. Our consumer and peer membership is part of our most active membership on the committee. I'm just make sure I understand the question. Are you asking if QIC could be a potential vehicle for initiating some of the process?
Yes. I see that the access to care, timeliness, quality, and outcomes are the, buckets. And I think that peer support ticks all of those buckets. So it feels like this is an opportunity for quality improvement of our system if we can support peer certification and the workforce development of peers in Sonoma County and the integration into paid jobs, secure paid jobs. And I know I'm talking to someone who's fully on board. I do understand that, but just to maybe elevate and hope that, QIC could potentially be involved in supporting implementation of SB 803 as we move forward.
Yes, QIC would be a good forum for doing that. That is the type of project that they typically take on and vet. And it is also peer employment pathways is one of the metrics by which we are measured in our external quality review. So it is something that QIC is definitely interested in. And we have utilized QIC before to work on projects. Like, as an example, we're working on a project right now with one of the subcommittees of QIC that's specific to the crisis stabilization unit, where they're actually working on putting in place a peer internship program at the CSU. And so if you want to, Carol, if you want to reach out to me and Erica by email, we could probably have you at our next QIC meeting to discuss.
Thank you.
Any other question? Am I missing any other hand? I don't want to. Okay, Tori, this time it's you. You want to share the certificate? Okay, this certificate will be sent across to you, Wendy. I have to admit look like your name has 2 W's and one is missing here. We'll correct that before we send it over to you.
Okay.
Thanks for all the work that you do. I know it may seem that you are behind the scene, but it's important work and we appreciate the work that you do. And we're hoping that the Mental Health Board will have more of a presence at your meeting. I was appointed to be the person, but unfortunately I have a meeting that same day at the same time. So I only attended one meeting and I have not been able to. So I think Bob might be taking that up, Bob Cobb.
We look forward to that. That would be wonderful to collaborate with Bob.
Thank you, Torin. Okay, next on our agenda, and thanks for coming for that presentation too. Mental Health Director's report. Is Bill still with us? Bill?
Yes, I am. Let's see, right now, as usual, recruiting is a focus. We will do interviews for the Substance Use Disorder Services section manager later this month. That position will be Diane Madrigal's replacement. Of course, Diane retired earlier this year. We will also be opening a position for nursing supervisors, and it'll be an important position for us to get filled. After that, we have a number of direct service staff in the area of, behavioral health clinicians, alcohol and drug specialists, and nurses. And I would say that recruitment is difficult, and we attribute that at this point to the difficulty that the labor market is experiencing with COVID, right? That folks are having a difficult time making the decision to return to the workforce, given that they have responsibilities at home, other life changes that may have come as a result of that. So a lot of our energy, as usual, is focused on recruitment. The Board of Supervisors in June shared that there is ARPA, American Recovery and Protection Act funding that's come to Sonoma County, and they will be leading a process by which to distribute those funds in the community. At least one of the processes is asking each of the county departments to submit proposals for projects to support with this time-limited funding. It's about $96 million to Sonoma County. $20 million of it is set aside for ongoing COVID relief efforts. The money needs to be encumbered by the end of the year 2024 and has to be spent by the end of the year 2026. They will be talking about this again at their July 27th board meeting and have announced a schedule that will play out to have them announcing their decisions at the end of the calendar year. They have on their calendar announcing the Measure O Oversight Committee at the August 24th board meeting, and they will be reporting regarding Measure O planning and decisions they're making about Measure O planning on August 31st. In areas of other important dates, the Psychiatric Health Facility, or the PUF, is on track now to open in December. So all of the construction and permitting is currently scheduled to be completed in November, which would have an opening date when they begin to take clients in December. I think I've reported in the past that we've sponsored 2 applications to the Mental Health Services Act Oversight and Accountability Commission for local projects. So a partnership of the Elizabeth Morgan Brown Foundation, Aldea, and Buckaloo is bringing a first episode psychosis program to Sonoma County. It's being funded through a variety of venues through the department, and as well with a donation by Kaiser Permanente. And we sponsored their application for the program to MHS OAC, and a second project sponsoring the Sonoma County Office of Education application for services to increase mental health services in schools. Both have been notified that they've been funded, but they've been in the paperwork process with the state. So we're waiting for updates about when that money becomes available and those programs can begin. We may at some point want to have representatives from those projects share information with the board or others about what's happening. And then lastly, we are tracking state releases of funding. So this year's state budget had generous amounts of money in the area of behavioral health. It's one-time money, which is, comes with its own set of problems, but nonetheless, these are opportunities to invest in building local services and systems, their infrastructure. So we're aware of the funds that are lining up to be available. No, the state has not announced yet any specific availability, but we, two projects we look forward to is an infrastructure development release. It'll be $750 million released across the state for investment in capital projects and facilities for mental health services, and a mobile crisis set of grants as well. So we're looking forward to that as well. So those are the items that I will update you about this evening. Thank you.
Any questions for Bill? Okay. I don't see any hands. Do you see any hands, Tori? Okay, thank you, Bill, for your report. Okay, we'll move on to Fair Coalition Intern report. Is this person at the meeting? Okay, doesn't look like the intern is here. Any other reports? It's about the PAN committee, Bob.
Yeah, since our last board meeting, we conducted 2 more site visits via Skype. Bob Cobb and I spent time with the staff, the leadership of Brown Street and Hope House, Thigh Gallo and Rita Larson. And again, they're 2 different supportive housing facilities. And we're impressed, I think, by the dedication of the individuals and how efficient they operate and how they provide ancillary services to people based on need. So we were impressed with them and think they're doing a good job. Bob, do you want to add?
I would concur with what you said. There was a level of dedication and to their clients, to the residents. It seems to be a pretty remarkable facility. Both facilities, in one respect, because there is no time frame, no limit on how long the folks can stay there, as long as they are benefiting from it, as long as they choose to, and although they are assisted in finding their housing in the next stage of their life. So that was explained to us, and that seems fairly remarkable when most of the facilities I'm aware of do have time limits for people. They can stay only a certain length of time. The other factor was the longevity of the staff. They're at least the key people. They've been there, in the teens, as much as 20 years for those facilities, which also points to their level of commitment to the work that they're doing. And I think we came away feeling very positive about what we had learned.
We're finalizing a report and we'll get it out to you soon. And then the mobile support team, Betsy Chavez and I spent time with Wendy. I don't know if hope I'm pronouncing your name correctly, Wendy Taphong, and learn more about the mobile support team. One thing Bill, that got my attention, how small the group is. I think 7 employees, and how, I guess from funding standpoint, they would probably benefit from additional funding if it's could be provided. But what are your thoughts on that?
Yeah, so, you know, mobile support is a relatively new service in California. So Sonoma started providing that service in 2012. And it was a part of the state's crisis triage grant. So there was a series of grants that were released to increase CSU, crisis stabilization units, crisis residential programs, and then mobile crisis triage. So over the years, mobile crisis has demonstrated itself to be, you know, a key part of everybody's crisis continuum, but there's no sustained funding source for that, right? So counties started these programs with the grants. When the grants ran out, counties used what funding they have available to them, frequently MHSA funds. So this program, you know, has had MHSA funds, it has had grants. It has strong support from the Board of Supervisors, which has allocated time-limited funds to it at various times. So the last time the board directed us regarding MST, it was last year, and they asked us to increase MST to have teams that covered all of the geographic areas of the county. So we are adding a team for North County. And then our services have been Monday through Friday, 1 shift, and they asked us to add Saturdays and Sundays. So we're in the process of that level of expansion. That's one area that's been hampered by the hiring difficulties, right? So we received this direction from the board last year, and then the pandemic started, and then we've been you know, unable to recruit. So our last set of recruitments did not fill all of our positions, so we're currently working towards that. It would be, I think there's reason to want to modify our model. The model was originally designed to support law enforcement response to calls that could have mental health and or substance use crises involved in their calls, and to offer professional support on behalf of law enforcement. I think the nation has seen that there's a benefit to moving those services further up the prevention scale, right? And to have them be, in some cases, the sole responder to what have been traditional calls to police, to take law enforcement out of interactions in which law enforcement's presence isn't necessary. The cities in Sonoma County have started to adopt this model. And in the case of Santa Rosa, we're joining them. We're in the process of joining them. It's not a done deal yet, but we're joining them, and we're merging our Santa Rosa MST team with their developing team in a way that will allow us to be part of the early dispatch process, right? So those calls that can send someone out before you send law enforcement, it adds a medical person to the team, and it allows us to spread our team, our 2 members out to cover more hours during the week. So we're hoping to learn from that experience and hoping that it guides efforts to expand MST and other mobile crisis models in the county. And then lastly, this is an area where the federal government, American Recovery Act funds, and other state funds may become available to the counties in this budget to expand mobile support further.
Would it be eligible for Measure O funds, Bill?
Yeah, so it is MST and CAPE, which was the school-based emergency response program that was cut in 2017. There is, I think, $4.2 million set aside for expansion of those services in the county. So the board, when they announce in August the results of their Measure O planning activities, we'll learn what they are going to be doing with MST and school crisis response.
Thanks, Bill. Just a final comment, our next site visit will be with West County Community Services, in particular their senior program, one with peer and then one's adult counseling services. So we just contacted them and Carol has agreed to participate in that, and then we'll be setting up time to meet with them. So that's all I have to report. Oh, go ahead, Carol.
Yeah, so I just wanted to ask Robert or Bob if he knows of the staff, the current MST staff, how many of them are peer support specialists?
MSC staff at this point, there are teams of 2 that are licensed clinicians, with the exception of 2 members who are certified in alcohol and drug.
Alcohol. I heard there's 5 clinicians and 2 alcohol and drug, and then 1 person, additional person as a program director.
So then the question is then to Bill, do you see room or opportunity for the expansion of MST using peer support specialists? Because I do know that they are part of the original model, the Cahoots original model.
Yeah, I think peers could be a part of a mobile crisis response model. Yes, and our MST team now works to link people with whom they have contact to peer support services and to NAMI.
Because, yeah,
I believe they shared with us that there's a partnership with Bucklew where they have some form of certification process, and we did talk about the possibility of a peer support process. And in that conversation, I think that they're very open to that. And I did hear your presentation last night, Bill, and with Mary Frances, and it was really comprehensive. I appreciated the fact that that you were bringing in the strengths of the current mobile support team, plus taking into account other members of the community and other partners of the community who have been working with community members that suffer from mental health. And so that's, I think it's a really great component to also the earlier presentation, to have more people be part of the conversation to really create a more robust and intervention.
Betsy, what did you think of our meeting with them? Did you have any thoughts when we met with and collected some information?
Sorry, Bob, what did you say?
Oh, do you have any comments you want to make concerning our face-to-face with them, with Wendy?
No, I thought it was my first site visit as a mental health board member, and I really appreciated the experience and the questions, the process. I think it allowed us to get to learn more about one another, and for us to bring it back to this group is beneficial in learning more about the services that are being delivered, and as well as maybe a possible connection in some of the gaps that are being faced. I think that that's important as well. I'd love for them in the future to come and perhaps speak about their potential collaborative work that they are doing with other community partners, just to see how that works, and perhaps for others to take on that same model or to offer some suggestions.
Thanks. Well, that's all I have, Peterson.
Okay, any other reports? Okay, no hands. Let me. Okay, let's do board planning. I'm not totally sure what we do on for the plan, because I'm not the one on the next meeting.
If Tori, if you're setting the agenda, if we can add some time to talk about SB 803 next steps and community consumer input.
I think you're muted, Tori. I'm not hearing you.
Tori, we couldn't hear you.
We didn't hear you, Tori. Yes, go ahead.
We still cannot hear you, Tori.
We have not been able to hear what you were saying, Tori.
We can see your mouth moving, your lips moving.
If you're on the phone, hit *6.
No.
Now you're muted. Your red microphone's up.
Carol, was your suggestion to have the next board meeting agenda added those items or what? Because typically the suggestion would be to have the executive committee build the agenda for the next board meeting. And so I think it might be more typical to make the suggestion that the executive committee look at the issue and potentially add it to the next board meeting. I'm trying to read Tori's mind. Okay, she
It looked like you. It looked like you read it, Bob. Any other item for the planning? Any other suggestions? She said she has added it to the agenda on the chat. All right, good. Okay, I don't have a report from, I didn't have a report from Kathy as such, so I don't have a chair's report to talk about as such, except for the vacancies that exist in District 2 and District 4, as well as District 5. Any other item of interest that we could talk about before we close? Any questions from the participants, other than the board members? Okay, if nothing else to discuss, then can we move the motion to adjourn the meeting?
So moved.
Bob Hills.
Come on, Bob Cobb, it's your turn.
Okay, I'll second.
Okay, the meeting stands adjourned until our meeting in September.
Thank you, everyone.
Thank you.
Thanks everyone for coming
Bye.
and for tolerating me for
Nice
this
work.
meeting.